So the setup, this is pretty basic, as with just about any procedure. You're going to have your prep. And this is a pseudo-sterile procedure, at least in my hands. When we're worried about septic joint, especially in the emergency department, I do worry and take extra steps to be a little bit more sterile. But most of the time, I'm swabbing the area with either providone iodine or alcohol. Usually it's alcohol. If I have chlorhexidine, I'll use that, but that's a pretty significant expense. And then when you're doing 20 to 30 a day, your clinic gets a little huffy about that. So practically, I'm using alcohol a lot of the time in clinic. Several swabs, and then I'll place drapes and towels as sterile as I can get them. Usually a 22 gauge, 1.5 inch is what I'm using for a knee, and a subacromial injection. If, depending on the patient's body habitus, you may have to change either to a 2 inch, sometimes even a spinal needle. So consider that as far as your needle is concerned. I use ethyl chloride spray for every injection I get. That I give, the patients love it. Whether a lot of it is placebo effect or if it truly is a topical anesthetic, and I think the latter, honestly. So I use that pretty liberally. And then gauze and a non-adherent bandage, pretty straightforward. So additional supplies for aspiration, I try to be a little bit more sterile as I can be with this. So sterile gloves, a sterile drape. I will infiltrate a little bit of plain lidocaine with or without epinephrine to the sub-Q tissue to ease the passage of an 18 gauge needle. A larger needle is going to hurt more, obviously, right? A larger bore needle. So I anesthetize for that. And I'll try to anesthetize the track a little bit. I'll raise a wheel. I'll go in until I feel like I'm near the capsule. And sometimes I'll even go into the joint. I'll try not to inject the local anesthetic in the joint, but I'll anesthetize the track as I withdraw. And then I'll insert an 18 gauge needle. And then you'll need something to aspirate with, a syringe. So either a couple of 30 milliliter syringes or a 60 milliliter syringe, whatever you have. So the technique. For the knee, my favorite technique to teach and to do is the supine superlateral approach. That's the example on the right here. So the landmarks are you're going to find the superior pole of the patella, and then you're going to drop down posteriorly on the lateral side, so down the lateral aspect of the joint, to below the lateral pole of the patella. You want to make sure you're under the patella, right? And your goal is to be able to go in parallel to the ground, as is, or to the table, as is demonstrated in this picture, but you want to make sure you're well under the patella. I'd rather people err on the side of going too far posterior than not going posterior enough. If you run into the patella, it's very difficult to get underneath it. As opposed to going too low, you can angle it back up if you hit bone. And if you hit bone too low, you're hitting the lateral femoral condyle, you aim up a little bit, you increase your angle a little bit so that you're going up above that and into the joint capsule or the suprapatellar space even, and injecting there. The seated approach can be either infralateral or inframedial. The example shown in the picture is inframedial. I typically do infralateral, but it's the same landmarks. It's just on the opposite side of the patella tendon, which is marked there with those two lines down from the patella. So you can choose one side or the other. A lot of my colleagues do it medially. I just tend to do it laterally. That's the way I'm most comfortable sitting with the patient. And and again, that's parallel to the ground. Your landmarks are, there's a little bit of a triangle. So you're going to find the infralateral pole of the patella tendon. So that's kind of two sides there, and then the tibial plateau. So those three landmarks, there's a soft spot right in the middle on both medial and lateral side. That's going to be your landmark. Parallel to the ground, should go right in. I hub the needle in both cases.